And today, our presenter can be ably described as the #1 doctor in Nigeria because he can decide whether you should practice medicine in Nigeria or not. He has such powers. Our presenter is Dr. Afolabi Lesi. The moderator would tell us more about him. And the moderator for today is Dr. Edwin Esegbe. I will ask Dr. Nvolaji Lawal to say a few words before we start. Over to you, sir.
Okay, thank you very much, Dr. Eletu. It's such a pleasure to um, to welcome everyone to this meeting, and it's a special day for me because today is my uh, last official day as chairman of this group, and I can think of no better speaker to share the moment with me, the moment of my sending off into retirement, than Professor Lesi, whom I've known for a very long time indeed, about 30 years now. And, is an accomplished pediatrician, neurologist, an astute clinician, uh, teacher, lecturer, and researcher, and administrator on so many levels. Dr. Eleto has told you that he can decide whether you will practice medicine in Nigeria or not as of today. So he's a very accomplished person, and also a doctor who has served the Pediatric Association of Nigeria very well. And it is on that note that I want to say a few things. And please permit me to say a few things because I have a few stories to tell. Just let me take about 3 minutes of your time. Professor Leshi was secretary of the association when I was president. And we worked so well together at that time and really took the association to unprecedented heights as at that time. And in the process, we bonded so well together, um, such that many years later, when it fell on us to author and edit a book on the history of pan, it was a very seamless exercise. Professor Leshi, I've had the honor of him reading my citation on quite a few occasions that I've received awards, and he can recite my citation off head. And he even knows things about me that that I don't know. And I have an interesting story, a fortuitous event that brought both himself and Dr. Eletu and myself together. And this was when I was president between 1998 and 2001. I was president, he was secretary. Dr. Eletu was doing his own thing quietly in UBA Medical Center, having finished his residency. And I got to know him there because I had relationship with UBA Medical Services, which is his boss then, Dr. Lamikora. And I looked at him, young man, I said, this young man that finished residency and went into UBA straight, there's something about him, he resembles me a little bit. So I took note of that. And then something happened in our executive. The assistant secretary, Professor Disu, suddenly took leave of absence because a sabbatical leave for 1 year. So it fell on us, Dr. Lesha and I, to decide whether to fill that position or to leave it vacant. We conferred together about Dr. Eletu, and we decided to invite him into the executive as assistant secretary. And that was how the journey of Dr. Eletu in the association started. It was based on the advice that Professor Leshi gave me as president that we invited him. And to cut a long story short, Dr. Letu did so well as Assistant Secretary and caught the eye of Professor Oshinusi, who was then incoming president in the same executive, that Professor Oshinusi now appointed him as her secretary when she became president of PAN after my term. Contrary to the way things happened at that time, when the president normally chose the secretary from from his center. So it was a very interesting situation that we all met at that time, and our journeys in the association started. So today we are here again, Dr. Lesi giving the lecture, Dr. Eletu the coordinator, and I as the outgoing chairman. So you can see how I'm very excited and happy to welcome him. I look forward to a very interesting lecture today. It's my pleasure to have you, Dr. Lesi, and it's my pleasure to watch you soar very high. And I know that the sky is still the limit for you. And I wish you the best as you continue to journey along. So sorry I had to take your time, but sometimes you have to give older people some time to say stories because you have to seize the moment. So thank you very much indeed. You are welcome, Dr. Lesi. Over to you, Dr. Eletu.
Thank you very much, sir, for taking us down memory lane. And I must say that I've known Dr. Lesi now for 35 years. We share a lot in common. So the moderator for today is Professor Edwin Ethegbe, who is a consultant neurologist at the Benue State University. He's a professor of pediatrics. He was the former CMD of Brigham University Teaching Hospital, Jos. He is the current president of the Child's Neurology Society of Nigeria. So, Edwin, over to you. Thank you.
Thank you very much, sir. Good afternoon, distinguished elders and members. It gives me great joy to moderate this presentation. Let me start by thanking GPIPP for providing this platform and for giving me the opportunity. So much has been said about Professor Lesi. Just like our distinguished elder said, we want to start talking about his accomplishment, our doing that. But I'll just crave your indulgence to say a thing or two about Professor Lesi, some of the things that we already know. Professor Lesi is a distinguished pediatric neurologist and neurodevelopmental pediatrician. He's a professor of pediatrics at the College of Medicine, University of Lagos, and consultant pediatric neurologist in the Lagos University Teaching Hospital. He's a foundation fellow and foundation member of the Child Neurology Society of Nigeria. So he's not just mentoring and training pediatricians, but he's also training child neurologists and allied professionals. He's our director of international collaborations. He's a fellow and past Secretary General of the West African College of Physicians, the fellow of the Royal College of Physicians, London. He's a fellow Nigerian Academy of Medicine. He's also a fellow of Academy of Medicine Specialties. He's the past provost, College of Medicine of the University of Lagos. He's the current chairman, Medical and Dental Council of Nigeria. And he's currently Deputy Vice Chancellor, University of Lagos. As you can see, he's not just an accomplished pediatrician and doctor, but he's also a distinguished administrator. Sir, the floor is yours. So go ahead with the presentation, sir. Welcome. Yeah. So.
Good afternoon, distinguished colleagues, ladies and gentlemen. I hope everyone can see my screen.
Yes, we can.
Okay, so thank you very much. So let me, first of all, thank Dr. Letu for inviting me, and also Dr. Mobolaji Lawal, who actually, what he didn't say was that he was a mentor to me. So if there's anything that I have achieved today, and whatever I am today, is by the grace of God and standing on the shoulders of people like Dr. Mobolaji Lawal. I'm going to stop sharing my video because my internet is quite unstable where I am. I'm actually in Kano. So if you don't mind. Can you still hear me?
Yes, we can.
Can you hear me?
Yes, we can.
Can you hear me?
Yes, we can.
Afolabi, we can hear you. Go ahead.
Can anyone
can hear
hear
you.
me?
Yes,
Yes,
I
we
hear
can
you.
hear you.
Okay, all right, so great, so I can continue. So why this lecture at this time? I mean, we know that CNS infections remain a major threat to lives of children and a significant cause of neurodisability among survivors. We also know that there's an association with the evolving trend of autism spectrum disorder. Clearly, timeliness of action is critical in mitigating the damage caused by CNS infections, particularly meningitis. While I appreciate the invitation to share knowledge among pediatricians in private practice, I think the major focus should be medical officers who are likely to encounter patients and initiate treatment even before the specialists like ourselves see them. Private facilities, I think for me, this lecture at this time is important in line with the vision of the Guild of Pediatricians in Private Practice. And that is private facilities have a key role to play in notification of diseases of public health importance. There's an assumption that maybe disease epidemiological trends can only be obtained from public hospitals and public facilities, and that is not true. Of course, you know the Ebola story. When Ebola first arrived in Nigeria, it was first identified in a private medical facility in Lagos. So what you do in private practice is also critically important in the whole narrative of addressing major public health problems in Nigeria. So the objectives of this talk, of this interaction, is that it's expected, because I know I'm preaching to the converted when I'm talking to pediatricians, but as I said, the focus is on medical officers, and it's expected that medical officers in outpatient and emergency room in privately run facilities should be able to correctly define what meningitis is, describe the epidemiology of the condition, describe routes of infection, talk about clinical presentation at 3 different age periods, determine and justify which investigations to order, drop a treatment plan, identify complications, and of course, initiate post-discharge care. So in terms of definitions, these are standard definitions. Nothing has changed about that. So meningitis is inflammation of the leptomeninges. Encephalitis is that of the parenchyma. Ventriculitis, inflammation of the ventricles. And the spinal cord inflammation is called myelitis. Nothing has changed there. So in terms of epidemiology, we know it's, as I said, it's a common cause of childhood morbidity and mortality. The actual incidence is not quite known. However, we know that from studies on nasopharyngeal carriage rates, it's quite high. About 6.2% of children and young adults carry Neisseria meningitidis in their nasopharynx. It is an airborne disease facilitated by overcrowding and by poor ventilation. A lot of us will be familiar with this graph, which shows the meningitis belt, which is that belt that stretches across Sahel, Africa. But you will notice that there's a little buckle which dips. So that concept of the meningitis belt also has a buckle now, which dips into parts of southern Nigeria, the southern part of Nigeria. And of course, in terms of serotypes, you know, Neisseria meningitis has a quite number of serotypes. And of course, we used to associate the epidemics to serotype A, which occur every 10 to 12 years, last for about 2 to 3 years. But there's a seasonal variation to the prevalence of meningitis in Nigeria, peaking around April. I'm going to show you some information on that. Now, this is a recent study from Nigeria and published. And it shows, you can see again what we had said earlier. So the greener the area, the higher the number of confirmed cases. And the red dots represent deaths. So you can see again this concept that meningitis is actually not limited. The one that worries us is not limited to just northern part of Nigeria, but you can see dips in southwest Nigeria and also south, southeast. So it's all over the place. It's a problem, and but the deaths seem to be limited to be maximal in the northern parts of Nigeria. This is also from the same study, which shows that indeed this is becoming, between 2022 and 2023, there was almost an exponential rise in the cases of meningitis as an outbreak. A study published in 2020 by Becky Tagbo, who most of us will know, again, it's just a confirmation that yes, meningitis actually can occur throughout the year, but there's a peak between February, March, and April from the Becky Tagbo study. Now, I want to talk a bit about this, and I think this is very important. So if you look at from the Becky Tagbo study in 2020, you will see that the most prevalent organism was meningococcal meningitis and H. influenza. But I think the key thing I want to just highlight here, that I've underlined it, is that the strain commonly which they saw was W, and this is very important. We've always thought that the major serotype that we see in Nigeria is A, and C is the common serotype in Europe, America, UK, and all that. But you can see from the Tagbo study that it's not just A, it's W, W135. Interestingly, the WHO study that I quoted, which I showed the map of Nigeria, what they found was serotype C. So I think the important thing that I want to emphasize is that contrary to what we have been teaching, that, oh, A is common serotype here, serosurveillance and surveillance of meningitis strains, of meningococcal strain, suggests that epidemiology might be changing. that while A was prevalent, but with immunization and all that, W and C are beginning to show their faces. So emphasizing the need for constant surveillance. We cannot rest and make assumptions of what serotype of meningitis is afflicting our children. We need to keep doing the surveillance and the monitoring and the work, because these things can change. In terms of routes of infection and how children get it, that hasn't changed much. It's still hematogenous, post-traumatic, CNS anomalies, and of course, contiguous spread, either from odontitis media or for the nasopharynx. And we've talked about what percentage of children carry these organisms in their nasopharynx. So that hasn't changed. I've said it's an airborne infection. In terms of pathology, that hasn't changed much. We are still seeing congestion with edema, exudation if it's pyogenic, and the location of the exudation may suggest the kind of organism we're dealing with. Exudation at the brain is typically tuberculous and meningococcal. In other words, you see cranial nerve deficits as part of the clinical presentation, and of course, arteritis leading to infarct of related tissue and nerve roots is also expected, and that's why you see neurological deficits often accompanying meningitis. So it's not unusual, and it's related to the pathology of the disease. In terms of common organisms, again, in the neonatal period, we're mainly talking about E. coli and group B strep. But however, I want to make a point, and I think this also emphasizes the point about the need for monitoring. In Luth, we're finding Klebsiella replacing group B streptococcus. So if you look at what we are getting out of Luth, and again, this might not be unique or peculiar to Luth, even in the newborn period, we may be seeing a changing of the kind of organisms that are causing meningitis among children. Of course, you can also have staph, Pseudomonas, and Listeria. In children under 5, we're still dealing with H. influenza. We said it before, Streptococcus, particularly in sicklers, and Neisseria meningitidis. But H. influenza will be the commonest organism in children under 5. In children over 5, it's mainly Neisseria, with H. influenza and strep playing a role. Other organisms also can be associated with meningitis, including Mycobacterium, viruses, big group, enteroviruses, herpes. Literally almost all the viruses can cause meningitis. Fungi and protozoa, particularly among immunocompromised children. In terms of clinical presentation, again, this is unchanged. We're still seeing that males are more commonly affected than females. Newborn, the presentation is non-specific. We've always taught that, and that has not changed. And often you are dealing with lethargy, feeding difficulty, very non-specific features that could also be the same features of sepsis, hypoglycemia, intraventricular hemorrhage, severe asphyxia can also do that. So there's an overlap. And of course, what we've always taught, which is also true, is that neck stiffness and full anterior fontanelle are not helpful signs, as they are absent in 75% of neonates with meningitis. That is unchanged. Infants, males are also more more frequently affected than females. Fever, nausea, vomiting. In fact, the vomiting, as we know, can be so severe and may actually be a cause of the severe dehydration among children with meningitis. Irritability, and then full arterial fontanelle can now be a major feature. In older children, we have the more classic signs of meningitis, such as neck stiffness, photophobia, headaches, severe headaches, the Koenig's and Brzezinski sign being positive, seizures, focal neurological signs, shock may be associated with children with meningococcal disease and H. influenza, and of course, petechial hemorrhages, the classic non-blanching petechial hemorrhages, which can be picked up with the glass tests where you roll a tumbler or a glass, a drinking glass, to show that it does not blanch. If petechial hemorrhages due to hypothrombocytopenia will blanch under pressure, in meningococcal infection, they do not blanch. And that's one of the ways in which you distinguish the petechial hemorrhage of meningococcemia from the petechial hemorrhages of thrombocytopenia. How might encephalitis present? Because we're talking about CNS infections. Again, altered sensorium is a key sign here with multifocal neurological signs. Let me just put a note here that when you have encephalitis involving the cerebellum, you may not have altered sensorium. So please note that yes, generally when you have encephalitis, yes, you have altered sensorium or coma, but it may not be so when we're dealing with encephalitis involving the cerebellum and the multifocal neurological signs. With an abscess, you have your typical high-grade swinging intermittent fever with focal neurological signs, or may present as a space-occupying lesion, where you have your typical signs of increased intracranial pressure alongside with the swinging pyrexia and focal neurological signs. In terms of investigations, I hope you can still hear me. Am I?
Yes, we can hear you, Afolabi. Go ahead.
You are quite audible.
I'm audible.
Yes, you are.
Okay, thank you very much. Okay, great. So investigations are still lumbar puncture that we would do, full blood count, blood cultures. CRP and acute phase procalcitonin have become important tests that you need to do now. Standard, electrolytes and urea, very important. PCR and viral studies, especially if you suspect a viral etiology. And of course, the test for TB
We'll try and get the speaker back on. I think he's falling off. Apologies for the break in transmission. He is trying to join. I'm sure will be with us shortly.
Sorry about the break in transmission. Can you see my slide now?
Yes, we can.
I apologize. Right. So if it's TB, there are tests we need to do. However, I mean, I've made a note here that as much as possible, cranial imaging should be performed. Can you hear me?
Yes.
All right. So cranial imaging should be performed prior to lumbar puncture to rule out SOLs. If any of the following features are identified at time of presentation, that means Glasgow Coma score below 10 is unconscious, you see focal neurological signs, you see cranial deficits, you can identify papilledema or new onset seizures in adults or severe immunocompromised states. So now, if there is no imaging, it is advised that you defer lumbar puncture if you see any of the above features or presence of Cushing's triad, which is, as we know, hypertension, bradycardia, chain stokes, breathing, or the child is in a critical condition, you should defer a lumbar puncture. This is a table showing the different abnormalities in the various types of meningitis, pyogenic, tuberculous, viral, and encephalitis. Now, in terms of definitive treatment, I think this is where we need to talk. If you're going to make a difference, it's here. So there's some general rules about definitive treatment. Again, these are the things that are well known to all pediatricians. And the first general rule is that treatment must be initiated as soon as diagnosis is made. And the golden rule is 1 hour. Investigations, while ideal before initiation of treatment, must never delay initiation of treatment. the of treatment is always intravenous. However, you can consider intramuscular as pre-referral treatment where IV access cannot be secured. Sorry, sir, it looks as if there's a recording that is going on. Can you mute that recording of myself? I think it's the one on YouTube.
Okay, we'll do that.
So for the neonatal period, cefotaxime in the doses that have been listed, usually meningitic doses, and an aminoglycoside. And duration of treatment is 40 to 21 days. A pattern in your hospital where the aminoglycoside is not gentamicin. You can use others. For it is mainly cefotaxime or ceftriaxone in meningitic doses, and the duration of treatment is 10 to 14 days. IV corticosteroids can be given with the first dose of antibiotics only in confirmed cases of pneumococcal or H. influenza meningitis, and IV corticosteroids are contraindicated in meningococcal meningitis. If due to herpes simplex, a herpes simplex, you can give IV acyclovir for 14 to 21 days. And of course, if it's tuberculosis we're dealing with, antituberculous treatment. Supportive treatments include anticipation and prevention of complications, maintaining hydration to full maintenance with isotonic fluids, not hypotonic fluids. So we do not use 4.3 dextrose in 1/5 strength saline anymore as the fluid for most things in pediatrics anyway. So we're talking about normal saline and Ringer's lactate. Seizure control. Anti-seizure medications are indicated where there are seizures, and its use should not exceed 3 months post-discharge unless seizures recur or recurring. Now, follow-up care. The important things that need to be done are hearing test or audiology at discharge or in the first 4 weeks post-discharge. It is important to assess for neuromotor sequelae within 4 weeks of discharge. And of course, if child has sequelae, child should be referred for appropriate rehabilitation. Psychotherapy should be offered to patients and the family as required. And then, of course, to initiate vaccine as indicated. I think most pediatricians know that every opportunity a child presents in a facility is an opportunity to give the missed doses of vaccines in the schedule. And specifically, if the child has not been vaccinated against the common organisms that cause meningitis, that should be initiated as well. For preventive treatments, vaccines remain the mainstay for preventive treatments. And of course, based on what we had discussed earlier, there's need to review vaccination guidelines regularly. And the decisions and policies should be based on current seroprevalence. Vaccine development should be based on what is prevalent in that environment. Fortunately, most vaccines are polyvalent, covering most of the major serotypes. So there should be no problem. But I think it's important as pediatricians, you need to know what vaccine you're giving the children under your care. Prophylaxis is not routinely practiced in Nigeria because it is difficult to confirm the diagnosis, laboratory, because you require laboratory confirmation of meningococcal disease. We do not use rifampicin for chemoprophylaxis because it is first line for TB treatment. So in this environment, if you're going to do chemoprophylaxis, if you have laboratory confirmation, then the close contact should be given either parenteral, single-dose parenteral ceftriaxone or oral ciprofloxacin. Gamma globulins are indicated in children who have immune deficiency syndromes. Complications as listed, including brain abscesses, cranial nerve deficits, dehydration, hydrocephalus, syndrome of inappropriate ADH secretion, subdural effusion. On a more long term, talk about deficits like hemiplegia, ataxia, hyperactivity disorder, language learning disabilities, autism, seizure disorders, and brain damage. Okay. So in terms of prognosis, well, so there are some prognostic factors. So for sequelae, the prognostic factors include presence of coma, impaired consciousness, presence of seizures, organism causing the disease, and low CSF glucose. Whereas the prognostic factors for death would be age. The younger the age, the higher the risk of death, presence of shock, low peripheral white cell count, and then presence or absence of disorders that may compromise the host response to infection. Fortunately, HIV is better managed now, and so we are not seeing children dying with HIV, with AIDS, dying from meningitis. So as I conclude, I want to emphasize some key messages. Epidemiology is changing, mainly driven by the introduction of vaccine and continuous vaccine development. And there's need for constant surveillance and updating of vaccine advisory. Clearly, more multi-center ongoing monitoring is required. And as I said at the beginning of my talk, private facilities have a key role to play in this multi-center monitoring that is required for disease surveillance. Treatment must be initiated as soon as diagnosis is made, and nothing should delay its initiation. And I said, remember the golden hour. As much as possible, treatment should be initiated within 1 hour of you seeing and diagnosing, making a diagnosis of meningitis or any CNS infection. The route of treatment is always only intravenous, and consider IM only as pre-referral treatment where IV access cannot be secured. Assessment and neuromotor deficits and initiation rehabilitation should be done at discharge or within 4 weeks of post-discharge. Meningitis is a notifiable disease, and private facilities are a great pool of important information in providing quality of our national data. So I think we need to get facilities. There's one thing the Guild can do is ensure that all major private pediatric facilities have on the platform where disease can be notified, either through the local government's notification officers. And of course, all facilities should have treatment protocols. If you don't already have one, I think that needs to be developed. And there are some guidelines for developing treatment protocols. I know that the Child Neurology Society is also in the process of developing meningitis guidelines. And I think this conversation we're having can only help in gingering the Child Neurology Society. And I'm glad our president is here to develop those guidelines for this and other neurological problems. So let me appreciate you for your kind attention, and let us go out there and continue the excellent service for which we have been recognized as pediatricians. Once again, I want to thank and commend the Guild of Pediatricians in Private Practice for their commitment to professional development and standard setting, and ultimately the quality of care in child health through their webinar series, which this is one of. Thank you very much for your attention. References as listed. Thank you.
So thank you very much, Professor Lesi, for the very sound and brilliant presentation. In the past 30 minutes or thereabouts, Professor Lesi has been talking about CNS infections with particular emphasis on meningitis and encephalitis. He's talked about the need to develop the competencies of doctors, not just in tertiary institutions, but those who are seeing patients in private facilities. He's gone through the whole gamut of clinical presentations, talking about specifics about clinical presentations and the peculiarities of the epidemiology that we see in clinical presentations, how epidemiology is changing, and so we are having particular serotypes, particularly BC, becoming more and more predominant. He's talked about the need to develop our skills in the areas of diagnosis and the need to commence treatment early, looking at the various types of infections that affect the CNS. He emphasized the need to start treatment within the first hour, and at the same time, while managing these patients, to look out for complications. As neurologists, we see children, and it's quite troubling, particularly when children develop complications. He's talked about the need for doctors to see infections of the CNS, particularly meningitis, as notifiable. And in other words, give these infections the attention, that they need. And he's talked about the need for developing protocols, So, sir, thank you very much. Before I ask that we entertain questions, I just want to highlight one or two areas that we discussed at the Child Neurology Society of Nigeria meeting, and you are there, and you made contributions to. I know in this meeting we are dealing with a variety of. The audience is variegated along areas of specialties. So, in looking at what is new as Child Neurology Society of Nigeria, our biggest challenge has been in the area of diagnostics, early diagnosis, and even having the competencies in making diagnosis. And one of the resolutions we reached was that we should be able to have centers that will be able to help or facilitate diagnosis, especially PCR diagnosis, when we have cases where, because they've had antibiotics and we cannot use our routine microbial sensitivity patterns to identify these organisms. We also talked about developing protocols that will be used nationally, because different centers have different ways or different modalities for identifying meningitis, and there is a need to have a protocol so that if a doctor sees a child with meningitis in Maiduguri, the doctor in Lagos knows that they are talking about, the same thing. So diagnostics and the need to have centers, that would aid or support diagnostics involving the Federal Ministry of Health is something that we discussed. And we also talked about new development in infections generally, particularly CNS infections, and then using artificial intelligence. That is new, but it's coming up. But to be able to do that, we must have robust data to be able to analyze, look at diagnosis, and even have predictive outcomes. This is even becoming more relevant in Nigeria as of today, where, without saying too much, we know how the issue of insecurity is affecting healthcare delivery. I mean, no matter how nationalistic you might be, if you hear that there's insecurity in a particular part of Nigeria, you might not really want to go there, even when there are outbreaks. But with AIs, we can have predictive patterns. We can have supportive diagnostic patterns, particularly in environments where some of these things are not readily available. So the use or the role of AI is something that we are considering and we are looking at as Child Neurology Society of Nigeria. Another important aspect that we are looking at is having longitudinal studies, looking at longitudinal studies involving those who have had CNS infections. Usually in our environment, recovery from CNS infections can be defined as return to normal functions in a child, absence of fever, and so on and so forth. But its impact on the long-term growth and development of a child is another thing that is new that we are looking at. So having said all of this, I want to thank Professor Lesi for stimulating, our thoughts and our processes of learning with regards to meningitis. I have a comment on the platform, on the chat box by Frank Mbanefo, who says, "Thank you, Prof, for the presentation. You prescribe full maintenance fluid. How about 2/3 maintenance to prevent syndrome of inappropriate ADH secretion?" Professor Lesi will respond to that while we look at or we take other comments. Thank you very much, sir.
All right. So maybe what I will do, since I can see the questions in the chat myself, I'll just take them and just go with the ones that I've seen.
Okay.
Correct.
So thank you, Dr. Mbanefo. So basically, we only talk about 2/3 maintenance where there is SIADH. The starting point is to do full maintenance. Unless you are suspecting SIADH, then of course you do fluid restriction because you don't want to dehydrate the child from the word go, especially if he does not have SIADH. So we do not, we prescribe full maintenance unless there's SIADH. What did I say, Dr. Duke? What did I say about prophylaxis to the contact? Chemoprophylaxis is given to the close contact of proven laboratory confirmed cases of meningococcal disease. So if you cannot have a laboratory diagnosis, then please do not initiate chemoprophylaxis. That's not, the recommendation is not to do that. It has to be confirmed. Because some of these drugs, you don't want to put pressure on them. Thank you very much for those who are thanking me. Acyclovir, yes. The use of acyclovir, it is part of empiric treatment. You have a child, you suspect a viral etiology, you should, as part of starting the empiric antibiotics, you should also start empiric IV acyclovir as well. Now, where you have viral studies which may come out down the line days later, and it is not viral, or your result, you've done your lumbar puncture and it's not looking viral, it's looking typically pyogenic, you can stop the acyclovir. But starting, you must start with antibiotics, IV antibiotics, and IV acyclovir. That is the recommendation. Okay, so don't wait to that antibiotics are not working and then you start acyclovir. No, it should start at the same time. You are starting empirically if you don't have information. Let me move on. Dr. Wigbo, thank you very much. If CSF analysis is not possible, how can we identify due to viral causes? Well, I mean, there are suggestions, there are clinical suggestions. So for instance, herpes, you see the blisters, you see the vesicles on the skin, you see in the mouth, may suggest herpes infection. But you're right, it's very difficult. And that's why you would have to do viral studies, either serology or PCR or something, where you can do it. If you can't do it, ELISA, serological test should be able to do that to point you in the direction. And if it's not viral, please don't continue the cyclovir. So it is an empiric treatment that the treatment of meningitis is empiric to start with. You don't have any information, yet you must start treatment within 1 hour. It is better to do overkill than underkill. Dr. Michael Okogbo says, in this climb, cause of practice litigation. Therefore, know your meningitis if you wish to practice in this world, part of the world. Always keep it at the back of your mind in dealing with a febrile child. I agree with you. The damage from meningitis is so severe that if you miss it, nobody will look very favorably on you that you did not err on the side of caution and treat. Dr. Odedoyin, I have had better outcomes when I use ceftriaxone and gentamicin and not cefotaxime, which I stopped using about 20 years ago because of my experience. Is it that cefotaxime is more reliable now? No, it's either or. So it's, as I said, you have to, your decision has to be practice situated. Nothing is better than the experience you've had in your environment. So if your environment tells you that ceftriaxone is better, please go ahead and use it. It's either or. In some environments, cefotaxime is still useful. We still use cefotaxime. I still use cefotaxime in Luth. So it is that you must use either of them. But your experience, your local experience should guide you. Dr. Douglas, thank you. In recent times, we have included vancomycin to antibiotic regime for meningitis. Yes, and so do we too use it. Of course, vancomycin is where you have methicillin, staph aureus, and some resistant drugs. We can use vancomycin. And if that is the experience in your area, I don't know where you practice, but it has to be guided. It is one thing to say, we have added vancomycin, we have done this. I am hoping that when you do that, it's based on microbiological sensitivity pattern from your hospital or from your area. We should be guided by evidence, not by feelings or what you've read in the literature. Evidence must support your decision making. So yes, I didn't say it because I was talking about empiric first line treatment. I would not use vancomycin first line unless I have reason to believe that resistance is very predominant in my area or in my practice setting. Dr. Bassohon, what do you recommend in terms of treatment in a situation where CSF culture yields no growth, but biochemistry is suggestive of meningitis? The experience of your environment, your laboratory, have a chat to your clinical microbiologist. What are they getting? Even where it was no growth from that particular patient, go to your microbiology lab, go to your infectious diseases specialist. What are they getting from the other cultures that they've yielded some growth? That should guide you. But empiric treatment is empiric treatment. Where you have no information, please continue with the empiric treatment for the required number of days and evaluate your patient frequently. If after 72 hours, you're not seeing an improvement, it's a reason to change or step up or do something different. All right? It's not that you give the antibiotics and wait for 10 days. No, you are reviewing your patients like we do every day, sometimes twice a day. And if you do not see an improvement after 72 hours, please consider changing what you are doing. Something needs to happen. Let me go on to the next. Dr. Wobo, what is your experience? Yes, we have experience with vancomycin. I practice in Louth. We do use vancomycin, but as I said, it's usually for resistant strains of organisms. Dr. Gunride, my past president, in the context of your lecture, kindly chip in a word about neonatal meningitis. I actually mentioned neonatal meningitis, that the recommendation that meningitis is non-specific. You need a high index of suspicion to diagnose neonatal meningitis. You also need to be very aggressive in treating neonatal meningitis. And the recommendation is to use a cephalosporin and an aminoglycoside, depending on the experience in your hospital. Dr. Uwaizuke, if we use 100% maintenance in an unconscious child being treated for meningitis, what symptoms would call your attention to the child developing SIADH? That's a good question. So SIADH is syndrome of inappropriate secretion, where you have excessive water retention. You tend to have a dilutional picture. You do your blood, your electrolytes and urea. You have a dilutional picture. It's also associated with cerebral edema. So you may have signs of raised intracranial pressure. Where you have those signs of raised intracranial pressure in the presence of a dilutional picture, then you will suspect SIADH. Of course, the diagnosis is made with urine, serum osmolality, and urine osmolality results, which would tell you definitely that this is SIADH. And at that point, you do fluid restriction. At what point should we consider tuberculous meningitis in view of the overlap between bacterial and tuberculous meningitis? Again, that is based on the experience. Where you have a fever that is going on for more than 2 weeks, where you have significant weight loss, you have to consider tuberculosis. You have other symptoms like cough as well. You have contact with somebody who has been losing weight or has chronic cough, you have to suspect empirically tuberculosis, and you may have to consider empiric treatment. Of course, there is an algorithm now for the diagnosis of tuberculosis, which is quite helpful, which raises your index of suspicion for tuberculosis. So, so the longer the history, most of the causes of meningitis are short, 48, 72 hours. When you're having 2 weeks fever, weight loss, night sweats, cough, contact with somebody, you have to consider tuberculosis. I think that brings us to the end of the questions in the chat. And I see Dr. Ajayi's hand is up. Ajayi Obi's hand is up. I don't know how much time we have, Chairman, Moderator.
Just a few minutes.
Please,
thank you very.
You can go on. You can ask
okay.
her.
Yes. All right. Thank you, Professor Lesi, my comrade. Thank you very, very much for the wonderful presentation. For me, it's as a public health specialist as well, I find it very disheartening that meningitis, the outcomes are usually very poor. And like you said, early diagnosis is very important. But I like to step back further in that it actually starts right from the parents bring the children into the hospital. I guess in private sector is probably earlier, but in the public sector, there's a delay. And I think it's important. I'd like to just make a comment to the child neurology that they begin to see how they can begin to educate the public. I know it's a challenge, but it's something we have to put our heads to the table to see how we can educate the public on these signs. In the UK, menstrual, the public knows about it. I know down south, it probably is not as common as up north. I was involved in the menstrual meningitis epidemic in 1996. And it's amazing. The people there know when it comes. The intelligence, we need to listen to them. When they stuck needles through their back and started coning, the people didn't come because it was the needle that was causing them to cone. So I think we just need to understand the dynamics. Meningitis is horrible. Sequelae are horrible. Death is horrible. So that's just a comment for me. And I think also we need to encourage the microbiologists to continue to compile the sensitivities on a yearly basis. So it makes it easier for us to introduce these antibiotics. I mean, in terms of antibiotic microbial resistance. That's just my comment. But thank you very much for the wonderful presentation.
So thank you very much,
Thank you very
ma'am.
much. I totally agree with you.
Request that the Child Neurology Society of Nigeria looks into community engagement and ensuring that, at the level of the community, persons are informed and are aware of features of meningitis is well taken, and we will look into that. I think the issue of the role of the medical microbiologist is also critical, is also crucial, just as the role of the regulatory agencies like NAFDAC that should look at it at indiscriminate use of antibiotics, availability of antibiotics, and how antibiotics are prescribed and they are utilized. So at this juncture, I want to thank each and every one of you for your participation. Your questions indicate that you sat through and listened with rapt attention. But our biggest thanks goes to our presenter, our lecturer for the day, Professor Afolabi Lesi, who, in spite of his very busy schedule, wearing so many caps and discharging his duties and responsibilities creditably. I want to thank you, sir, for creating time to come in to share your wealth of knowledge with us. I want to thank my big brother, Dr. Eletu, who always calls and makes sure that one is given the opportunity in sharing or interacting, providing knowledge about the care of the Nigerian child. And to GPIPP, we are grateful. So I want to hand the whole presentation back to Dr. Eletu. Again, thank you very much for the opportunity. Thank you, sir.
Thank you very much, Edwin.
Good afternoon, sir. Good afternoon, sir. I'm so sorry to jump in like this. I was exited and I asked a question earlier. I don't know if it was answered, sir.
Okay, what's the question?
Yes, I was asking. Yes, sir. I was the person that asked the question about cefotaxime and ceftriaxone.
Yes, I answered it. I said that yes, it depends on what your experience is in your facility. It's either or. Either you use cefotaxime or you use ceftriaxone. So if your experience in your practice setting is that one is better than the other, please go with the one that has been shown to work. But I was saying that it has to be based on microbiological evidence from sensitivity, not that you just switched. There has to be a reason and evidence to support the switch to the preferred cephalosporin. That's all I said. But it's okay to use it.
Yes, sir. Thank you very much, sir.
Thank you, ma'am.
Thank you.
Sir.
Thank you very much, Afolabi, for the excellent presentation. And I know you're in Kano, and it's a busy time for you, but you still found time to make this presentation. For those who do not know, Dr. Lesi is the current distinguished pediatrician of the Pediatric Association of Nigeria. So you can imagine how many caps he's wearing while making this presentation.
That is not a cap.
Well, it's a cap for the few people who have it, who have won that award. So well done.
Thank you very much.
A lovely time in Kano. and visit the historic places in Kano. Like I told you, I lived in Kano for a while. So when we talk privately, I'll tell you where to go. So to round up, I'll hand over to Dr. Mobalaji Lawal to say a few words.
Yeah, so thank you very much. Congratulations, Professor Lesi, for another feather in your cap. Surely there's no hiding place for a goldfish. So right on. So thank you again for the most informative and lecture, very lucidly presented, and therefore very engaging, as shown by the various comments and questions that have been asked, and also a full house of 100 people to the end, and lots more people in the YouTube section. Thank you. Thank you again, Dr. Lesi. Thank you, our very able moderator, Professor Esegbe. I forgot to mention that when this group was started about 4 years ago, I had an in-depth discussion with Professor Lesi about this group and shared the vision with him and all of that. And he was very supportive of the group. He offered very many suggestions at that time, if you remember very well. And he also pledged his full support in whatever way we needed it at that time. And so, apart from, he's not just a casual visitor here. He's actually a friend of the house and an advisor. And I know that when he's finished with all these things, when he finally retires, he will still come back to join us here. So we are waiting for you when you finish all this. When you retire from all these things, you will still come and join us. So we'll be happy to welcome you. So anyway, thank you very much. We are very grateful to have you here and for the sacrifice in joining us from another engagement. Thank you, everyone, and bye-bye from me. Over to Dr. Letu if he has any other thing to say.
Thank you very much, sir. So we'll bring the meeting to a close. And just to say again, thank you, Professor Lesi. Thank you, Professor Esegbe. Thank you to all the members who attended this webinar. Next month, we shall be talking about AI. So I imagine that the turnout will be as good as it's been today. So on behalf of the Guild, I say a very big thank you to all of you and have a wonderful evening. See you next month. Bye for now.
Yeah, bye-bye, everyone.
Bye-bye.